I'm Nancy, and this is Brenda.
Hi.
And we're going to get started. And we want to let you know that this is really a crash course in hospice care. Primarily, it is being given to nurses, but we are hoping that all clinicians that are taking part in this will be able to increase their in-depth knowledge and educate anyone who is new to the end-of-life care. It really is hands-on, nitty-gritty for the needed care of the hospice patient. We're using it as an excellent tool for training and recruiting nurses, and it really helps to standardize the practice of the whole hospice team.
So I just want to start with, we have immense respect for our seasoned hospice colleagues and for those who are new to the field of hospice. We all know that hospice is growing and there's a need for skilled team members. And historically, hospice has been built on a team approach, and it remains that way. That's the basis of its success. And it truly does take an interdisciplinary team to give the best overall care.
We want to review a couple of the objectives and goals that we're looking at for this seminar. And I'd like to say thank you for thinking of questions. We're hoping to have some time at the end, but do hold those questions until the end. We're going to scoot through this as fast as we can. So we're hoping at the completion of the program, the clinician, both new and experienced, will be able to assess and build a plan of care for the client and the entire care circle regarding the specific physical, emotional, and spiritual needs of the patient. We're hoping that you'll become more efficient in identifying and managing the priority symptoms that need to be taken care of, and that you'll have an increased understanding on managing medications and how to dispense them, those medications that your medical director has approved. The clinician is focusing on the approach of prevention. That's really what we are looking at very carefully, and actually we've adopted a motto, care is treatment.
So as we all know, the nursing care plan, it's a live document. And the purpose of it is to communicate individual care needs and what's best for each patient. Nurses are getting farther away from the bedside, and we really, this care is treatment really is about getting back to the basics at the bedside. It's a time-tested way that is sustainable and has the best outcome for patients. Care is treatment. Nurses and nurses' aides need to be proficient at this bedside care so that they can provide it, model it, and train caregivers and families. In fact, care is not only treatment, I believe it's also the art of compassion. It is possible to have good, healthy boundaries at the same time engaging and connecting with your patients, your families, and the entire care circle. It actually saves time to truly engage, and you have increased job satisfaction. I watch the caregivers that I work with in facilities. They mimic my care. And I don't often teach at them directly. I do ask them to read the booklet and watch the videos, but I work with them side by side at the bedside, and I feel like that has the biggest impact on providing and showing care.
And I think that's another thing that Brenda and I do is, even if they're not ready for bedbound care, whenever we see a client, we try to find some way to touch them and provide some level of care, even if it's a leg massage or something like that.
Yeah. On page 2 about the dying body, I think we've done a really nice job. It's a gentle way to just literally let you know how the body dies. So we know that the body knows how to die. It's a normal, healthy part of living, but there's a process to it, spiritually, emotionally, physically. And TV, movies, our social status doesn't portray the realities of how we really die.
And they rarely use the word death and dying.
Right.
They always say passing away or something like
Right.
that.
I always like to say to nurses, newer nurses in end of life that I'm working with, it's really important to ask yourself your own personal feelings, how you feel about dying. And some of us lean towards that, others lean away from it. There's no right or wrong, but what's important is that you really are clear with how you feel, because your patients and your families and your colleagues, they will feel how you are about it. And so I really think it's a good time to just check in with yourself. Is this the field for me?
And they echo your confidence. If you go in feeling confident that you're there to handle death, then they're going to feel that, and they're going to be reassured.
Yeah. If we make it seem normal, it's going to feel more normal. like to think of us, we have a life bubble that's all of us on this webinar. Our life bubbles, they're big, they're pulsing with lots of energy in and out. As we get closer to end of life, our bubble starts to shrink. There's less energy pulsing, it starts to detach, and it's a normal, healthy way to get to end of life. A really quick story that I use with my patients all the time. And I've been at this 30 plus years, and early on I had a patient named Grace, and I adored her. And it was in the old days in hospice when you had patients for 2 or 3 years, which we don't anymore generally. Over that time, I watched Grace lose her ability to walk, her vision, her hearing, her independence. And one day I was massaging her feet. I'm like, Grace, I just don't understand why you have to face so much loss at the end of life when you've given so much in life. And she very wisely patted me and said, Brenda, if we never lost anything, we'd never let go. And that really has helped shape my career as a hospice nurse. On page 2, we talk about how much time is left, and that's always the big question that comes up. And as soon as I hear that question, or I sense they're wanting to ask it, I said, let's talk about how much time is left, because it's a really good question to ask.
Sometimes we just feel that patients and the family, they're embarrassed to ask that. They feel like there's something wrong with just saying, well, how much time is there?
Right. So by encouraging that question, first of all, they feel relieved. It's okay to ask that. And I explain, we're not very good at guessing. The medical system, they've studied it. We consistently get it wrong. The ones who even get in the ballpark tend to be hospice nurses. It's much better to think in terms and speak in terms of months, days, and weeks. At end of life, when somebody is declining monthly, they tend to have months. When they're declining weekly, they tend to have weeks. And it's clear down to days and hours. And when you put it in those terms, and I say, so do you see a decline? I ask themselves or their family, like, yeah. And it gives them an internal sense of how much time do they have left. And that's comforting.
It's really good to plant that seed right at the beginning too, because as things start to change and the decline quickens, then they really want to be more specific about it.
Yeah. I often say early on, your mom is, when we're talking about transition and active dying, because we want to plant that seed kind of early, is your mom isn't there yet, but she's approaching, and as she's approaching, it'll become more obvious. Because you know her best, you'll know more. So I want you to read that, and you tell me when you think your mom is starting to transition. And just that shift of power, almost, if you will, it feels comforting for them, like, okay, and they tend to be more accepting. It also helps to, when you're planting that seed ahead, that you're going to need 24-hour caregiving through transition and active dying to plant that seed so that you avoid the care crisis in the end. Okay, symptom management. The fact is, when it's done well, people not only live better, they live longer. And there's some studies really validating that. I often say to patients, hospice is less about dying. We all do that. Hospice is more about living the best we can until we die. And in order to have good symptom management, you have to establish trust. And the best way to quickly do this is by addressing their first symptom simply.
And if you can address that first symptom and be successful, then that builds trust. It's like a circle.
Yes.
Start with trust, carry off with a good symptom management, get more trust, and that works all the time.
I'm going to show you real quick. We have a contact list, and it has information on the hospice team, who's your team. It has family team, and we know why it's obvious. There's obvious reasons why it's good, but what's important is whether it's the social worker or the nurse filling it out on admit, you quickly figure out who's the power position, who are the main players, what's going on. And also families like, oh, I have my own team. So I think it's a really good thing to go through on a mission.
Okay, we're going to get into some real meat here, and we all know that as a hospice nurse or team, that medication management is very, very important, and it is probably the most time-consuming endeavor that we are taking care of when we're caring for patients. And it's really important that the patient and the family are brought into the goal right away, and that they're reassured that we're not going to be stopping all medications and just starting everything for hospice. Our goal is to use the right amount of medication to achieve that desired effect, which will promote the best quality of life possible. And we also want to teach them how to successfully give medications. They haven't done this before at the level that we're going to be helping them. And as many of you know, patients are very resistant, especially today with the narcotic crisis that we have in the country. They're really worried about the medications that we bring into the home. And they've had almost always, there's been somebody in the family who's had an experience of, and they'll say, oh, Uncle Joe came onto hospice and 2 days later, hospice killed him with the morphine. I mean, it's very common that they have a negative feeling about the quickness of the death and the medications that were utilized. Even though they were utilized appropriately, they feel that we have done that job of using too many medications. So it's really important to go slow, let them know right from the beginning we're only going to be using what that patient needs. And we often say very clearly, the patient is not dying because we're giving them medications. We are giving those medications because the patient is dying.
And when you get that resistance, my brother died because of hospice, I don't resist that. I'm like, there's old hospice, there's new hospices, it's done, there's a lot of different ways it's done, and that must have felt really bad for you. And so just don't try and say that didn't happen for them.
Sure. And of course, we always follow the adage that you're only going to add, if possible, if your symptoms are manageable, you're going to only change or add one medication at a time, so you're able to assess the effectiveness of that medication. The other thing that comes up often when we admit patients is patients expect that we're going to stop all of their regular medications and we're just going to move in and change everything. And we emphasize immediately, if it ain't broke, we're not fixing it. We will leave them on, they like 12 different supplements that they're having trouble swallowing, but they don't want to give them up. Oh well, we're going to let them go slow, build that trust, not make a lot of changes, get that trust before we really start making changes, or they demonstrate that it's really hard to swallow that big fish pill. I want to get rid of that fish oil.
Just do what's important.
Yeah. So again, we want you to use words that are really designed to take the fear out of these powerful medications. Throughout this program, we're going to give you some verbiage that will help you address these specific issues. And we will use repeatedly the 3 phrases, I wish, I worry, and I wonder. And these work really well to introduce a concept and reduce fear and allow the patient to feel heard.
And state the facts.
And state the facts, right. I wish you weren't having so much pain right now. I worry that by not trying this medication to relieve your pain, that you're using all of your life energy to feel and fight the pain. I wonder if you would sit with me, try some medication, and I'll be right here with you to see how it affects you. I wish, I worry, I wonder. We're going to use it a lot as we go through this. Emphasize that what you're bringing in, and most hospices do deliver a comfort pack, a rescue medication box, and I always say these are your tools in the toolbox. Put them in the closet if you don't need them, put them in a safe place. We don't want pets or children to get into them. We may not be using them, but at 2 o'clock in the morning, if there's a problem, we want to have some tools. Just like you have a screwdriver out in the garage when you need it, we want those medicines on board. Don't be afraid to also instruct what's the largest the largest amount of prescriptions. So if, for instance, your medical director has given you a range of 5 to 20 milligrams of morphine every hour, sometimes it's so reassuring to the patient to tell them, you can have actually the whole dropper full, 20 milligrams every single hour, and they're aghast. And then I just say, yeah, you wouldn't have had that prescription if it isn't safe, and we're certainly not going to start at that level.
And I point out to new nurses all the time, if you're needing something every hour, there's something wrong with the regimen.
Yeah, very true. We always try non-invasive steps first, of course. And again, at admission, we don't go through, unless they have really severe symptom management needs, which of course we would use them. But if they have a couple of days and you don't have the rescue meds in your hand, we maybe mention them, but we do not go over them in detail. We want the client to see them, feel them. We want to open the box and do that together. I'm going to show you a few tools that we use, and when you get to there's a couple pages on medication. I don't think you can see this very well, but maybe Deep can go to, yes, right there, the medication management page. I filled it out. On the top part, this is their scheduled medication, their MAR that tells what they're taking daily. And I tell a patient, you don't have to fill this out. That's my job. If we change the times that you get it or the prescription dosages, I'm going to change that. Down below, you're writing in all of your PRN medications, and I've actually put in the ones that we use regularly. So that gives the full range of your PRN medications. The next page is actually a work page for the patient and the family. It allows for all PRN medications, and of course we let them know that's your only work. I want you to write down every medication that you take that's extra. And that's going to help me manage your medication. If you took 5 doses of morphine by the time I get here tomorrow or the next day, fabulous if that worked for you. But guess what? We might need to put you on a scheduled dose. So this is going to help me get your scheduled medicines on board, because what are we looking for? We are looking for a beautiful, consistent sense of being. We don't want to have these ups and downs with symptom management.
Waiting for that next PRN dose.
Right, but we want them to know that we want to stay ahead of the symptoms with small doses of medication and then use the PRNs as they are needed. Okay, when we are in a home and it's getting close to transition, I'm going to show you another thing that we do. We have big computer paper, and we write out an actual MAR for the patient and the family. So they have the date and the time, exactly which medications are being given, and all they have to do is put their initials in or check it off so that anyone in the family would know. We also on the table, oh, that's the wrong one.
Yeah.
Pardon me, I gave the wrong one. This is the actual MAR that tells them what to take when, and it also gives some space for PRNs. On the table, as Brenda's holding up, we mix up our syringes so that this is a no-brainer for the family, so that they know that on this side in this cup is 5 milligrams of morphine. And then if they're also getting some morphine and lorazepam, that's in this cup, and they are labeled on the cup, and they're also labeled on the paper.
This may seem like time consuming. This saves so much time in the long run.
And you want to take as much anxiety away from medication use for the family so that they use them appropriately, which will really advocate for the patient's comfort. And of course, we have some other tools. You're probably all familiar with the 7-day MediSet. Just love this thing. I fill it up whenever I can because it helps me stay ahead of their meds, know when their refills are.
Know when they've missed meds.
Yeah, if there's about 3 or 4 of them that aren't taken out, you know what they haven't done.
It's set up, this matches the routine med schedule.
Absolutely. And so, of course, if you don't have one of those, guess what? I've even used ice cube tray or even a muffin tin. Whatever you have that works, that will help this family understand how to use the medications. And even right now, we are lucky, if you go on Google or Amazon, you can buy an automatic pill minder for just $50 to $70 for that patient that maybe wants to maintain independence as long as they can, but they have a little bit of memory problems. It's gonna pop up that dose when they need it.
That pays for 2 hours of caregiving right there.
Exactly. All right, moving on to some more actual symptom management. We're going to start with alphabetically.
Anxiety and agitation, and we've set up the symptom management by alphabetized, but I think it's appropriate always to start with anxiety and agitation. It's a normal, healthy end of part of life to expect to feel anxious. In fact, I say to people, I think it would be a little odd if you weren't a little anxious about facing the end of your life. Just saying that alone, you can just watch the anxiety start to melt a little bit. there tends to be a little bit of negative word with the anxiety with older people, the traditionalists. They see anxiety or agitation as a weakness. So I often find myself using the words like, do you find yourself fretting more? That rat wheel spinning? Are you worrying about things? And they're more willing to talk about that in general. And I assure them that there's some things that we can do to help and to help them feel calmer and get some sleep.
I'm going to interrupt Brenda just for a moment, because what you're looking at and the anxiety and agitation, the way the booklet is organized, just so you have a feeling, everything that a client can do or a caregiver is on the left side. So it is an overview of general good caregiving, care as treatment. And then on the other side is a blank page that allows the case manager, Brenda, to actually write the specific instructions for this patient, because we always are trying to individualize that plan of care.
Yeah. And over there you can see we talk about helping families understand what is anxiety, what is agitation, when do we address it, how do we address it. We first start addressing it by talking, and more importantly, by listening. I like to ask really open-ended questions, and then I make myself wait. And just give some space for it, not till it's uncomfortable for them, but try to count to 10 or 15, because often around 7 to 12 that answer comes out.
We don't have time to really talk about time and management, but we have found that if you are a good listener, you are totally focused on the patient, you're looking in their eyes, as Brenda said, you are waiting for them to give you the answer, you will save so much time, because you'll really get down to the bottom of what's bothering them. You won't have to ask many times, and they won't have to be redundant or try to talk over you if you're interrupting them.
Exactly. So open-ended questions I often use are, so tell me what's important to know about you. Who are you, and what do you want me to know about you? You learn a lot there. Tell me more about that. Help me better understand. I often say, because when you're the one sitting in the chair dying, it's a lonely place. And I try and acknowledge this. I say, does it sometimes feel lonely sitting here? I mean, you have all this family loving you, taking care of you, but it's kind of lonely. Like, yeah, it is. And so being seen and heard. There's 2 questions I like to ask early on in after admission. And the first one is, what is it that you worry about or fret about? We all have something, not facing death or not, that kind of niggles at us. And I encourage you to say that out loud. You don't need to say it to me, but to yourself, or even write it down. And what we find is by saying that worry out loud, it takes some of the power and bigness away from it.
And by this time, generally your social worker, the MSW, has had an opportunity to meet the patient. And remember, they are truly the professionals who are family counselors. That's their strength. So if there is anxiety and some real emotional issues, it's time to really let your social worker know so that they can get in there and do their beautiful work.
Yeah. The other question I always ask, what do you hope for? It doesn't need to be realistic. Just say out loud what it is you hope for. And I also say, hope is kind of like a shapeshifter. As our realities change, our hopes change. But it's okay to keep hoping and to hope for whatever you want. Here's where wish, worry, wonder I love works really well. I wish you weren't facing your end of life right now. I think you're a little young, don't you? I worry that your time is short, and I wonder if there's some things we could do to help make the most of your time. Recently, just last week, or a couple weeks ago, I said this to a 57-year-old woman who is being, kept alive on TPN and dialysis. And at about count of 10 of silence, she said, "Oh, I need to make amends with my daughters." So I got a social worker, chaplain in there ASAP, and sure enough, she made amends with 2 of her 3 daughters.
And she moved to a facility that I actually am taking care of patients in. So she became my patient, and it's really true. She found peace, and it really helped to have her know what she needed to do.
So what to do? So as anxiety and agitation can escalate into delirium at end of life, and so we're gonna. And I tell all my new nurses, I put this on their phone, CHIMBOP. It's an acronym, and it's a industry standard. Causes of delirium. First one, constipation, no surprise. Hypovolemia or dehydration, hypoglycemia, infection, medication, bladder issues, most commonly retention, oxygen deficiency, and pain. And lots of these things are to be expected, but when you're in the chaos of somebody in delirium, it's hard to think what's going on here and just bring this up and say, okay, what are we dealing with here? Where's the potential problems?
It's really important to know, kind of watch the difference between anxiety, they're fretting, worrying, spinning. That's really different than moving into true agitation where they can't sit still.
Yeah.
They're
Up every 30
confused,
seconds.
maybe hallucinating.
Yeah.
So you really have to watch for the difference between, and they have different treatment plans that Brenda will talk about.
We're going to talk about medications a bit, and I think we always have to start, of course, with you need to follow within your parameters with your hospice doc and what those orders are. There's benzodiazepines, which are very, lorazepam being one of the most common, and Valium is also often used, diazepam and alprazolam. Certain situations will use midazolam. Then there's your anti-seizure medications that can work real well. Depakote, we love Depakote for the elderly demented patient who just needs a bit of a mood stabilizer, and phenobarbital when sedation is needed. Then you have your old and your new generation antipsychotics. I'm going to talk a little bit more about Haldol, which with palliative medicine has really come into vogue again. Seroquel is getting really popular out there, and there's a great use for it, but sometimes people are just getting over sedated with it. And then Zyprexa.
Yeah, and if it's used in a large dose, say at bedtime for sleep, it doesn't really work so much during the day, and we found that if you break that dose up into small, every 6-hour doses, it's the same dose will work better all the way around.
We often get, just yesterday admitted somebody on 100 milligrams 3 times a day, and they're just sedated, and so we cut it back. Last week I started a Parkinson's patient on just 12.5 milligrams twice a day because they couldn't have Haldol, and the mental confusion just cleared right up. And then so back on track, and then Thorazine is still often used. And let's not forget, if somebody's going to be on hospice for a while, let's get a social worker out there, do a proper depression assessment, and an antidepressant may be very helpful, especially if they've got some time in them. But knowing it's going to take 4 to 6 weeks to really kick in. When I'm talking to people, in our comfort pack, we have Haldol and lorazepam, and I try and I describe them differently to families. Haldol is when it works right on the brain, and the brain is spinning, and you can't get to sleep because you can't stop perseverating or thinking. It just slows it down enough to step off. Haldol is also great because it's not sedating, it's not addictive, and it's just a little more gentle, and it works really well for elderly people.
It's really good for hallucinations.
It is, and it's really good with dementia. Lorazepam works more on the entire central nervous system. It kind of soothes it, and it's wonderful for sleep. I tend to use it for people younger than 70, but I always tend to use it in the active dying process because it's very soothing to the central nervous system. As oxygen goes down, CO2 goes up, they can get kind of twitchy. It's very soothing to that.
And it's a great adjunct to use with a narcotic if you've got somebody who's really short of breath.
Exactly. And but be careful, because the studies show when you start using benzos like lorazepam, the rate of falls go up. So I tend to try and use Haldol within limits, and we have very clear limits on how to use it, and lorazepam more for sleep and active dying. I think that's about it. Of course, we're just touching the tip of the iceberg, so I'm going to have Nancy move on to bladder.
Okay, as we turn to bladder, I hope you'll notice that the color is yellow. Brenda and I had a whole bunch of fun choosing the colors that seem to go along with the symptoms. So just as an aside, that was really fun for us. And what's our goal? The goal is to be able to urinate normally and naturally, and to prevent and manage problems when they arise. We all learn very early on to hold our urine. By the time we're about 2 years old, we're expected to sit on the potty. And so it is very, very difficult for an adult, anybody who's an adult, to be able to release into a period of, or a state of incontinence. So we always try to recognize, it's really important that you recognize your own need to urinate. I mean, it's easy, a busy person can hold your urine and you can actually get into a habit long enough, and this happens with patients too, who hold their urine, they retain it because they don't want to be incontinent, and then you can get a UTI from it. So we of course want to be really careful with that. Don't sit on your urge to urinate. And so, you know, just do your best to allow that patient as much privacy, dignity, get them to the bathroom, have your caregivers getting them to the toilet every 2 to 3 hours, really write it in their care plan, schedule it, that they go to the toilet so that they can prevent incontinence. Put that commode next to the bedside, sometimes at bedtime, so they don't have to go too far, etc. So what do we do when they're really restless? And this is with somebody who's getting into maybe transition, active dying, and you're starting to go through Chimbop, and guess what? You get down to the bottom and we're looking at urination, retention, and it can cause just extreme agitation. And it can happen even when someone is having overflow. So you can have somebody who's retaining urine, has a large bladder, and then they still pee a little bit all the time. And for caregivers, that's really difficult. You'll ask them and they'll say, oh yeah, they had a wet brief 8 hours ago, and you think everything's fine, but their agitation starts to build. So at some point you may want to get that catheter put in and really check to see if there is some retention. If you always use a Foley, do not use a straight catheter. You want to be able to leave it in if necessary if you find there is retention. And you watch that patient. If they get quiet and relaxed, you know that was the source of their agitation. It's really important to teach a family how to take care of a catheter if it's in. It's all written in the booklet, so we don't need to go over that.
That's great, especially in facilities and caregivers, like you need to do this catheter care every day.
Every day.
I mean, it's all written out right here.
Every day. So just going to talk a couple things about catheters. All nurses have had catheter experience. Want to talk just a little bit about both men and women. We are often going into darkened homes, and to try to see a woman's urethra, it's a challenge. So everybody, get yourself a headlamp. Carry it with you all the time. You probably do.
I use my headlamp for everything.
Yeah, wound care, everything. So get yourself a headlamp. Get some help if there's family member to get the patient into the stirrup position. Medicate if they have any dementia and you know that they're going to be uncomfortable. All we women know what it's like to get into stirrups. And if that makes you feel uncomfortable, plan for it ahead of time. Use pillows and someone to help you if possible.
I really try and have a family member that they're really comfortable with, or a caregiver up at their head, talking to them, explaining it's just as nurses, we're getting a catheter in, so that's comforting, because when you don't know what's going on and somebody's messing around down there, it can be it can be traumatic.
Don't even question yourself when it comes to a man. Use a Coude tip catheter. Don't even ask them if they've had problems. Just use a Coude. And sometimes if they're an elder and you know they're going to have prostate enlargement, just as all men do, you can take as Brenda says, just get a cath tip syringe, fill it up with some lubricant, and actually fill up the urethra with lubricant, not just coating the catheter. Start with placing that tip so it is tipped up towards the nose. And if you have trouble getting it in, if it's bending, causing discomfort, then if you're not familiar with doing this very often, a lot of nurses think, oh, I should get a smaller catheter so it'll slip under. If I did a 16, I'm going to get a 14. No, the urologists say do not use a smaller catheter. What you want to do is go to a larger catheter. Go to that 18, because it is stiff enough now that it could pop under that prostate.
And spin as you go in.
And if you know that it's going to be a problem, this is a patient who's had prostate cancer, and you know at some point you're going to need it, get an order for some lidocaine jelly, have it on hand in the home so that when you change that catheter, you can fill the urethra with lidocaine and wait 5 or 10 minutes so it's not uncomfortable for the patient. Okay, we'll move on to bowels.
Okay, bowels, one of my favorite subjects. They call me bowel queen. I think we're all bowel queens. I even had somebody on the street once say, I know you, you're the bowel queen. I'm like, oh my. So getting somebody's bowels moving is one of the biggest trust builders you can do right away. And we all know that most people come onto hospice with some kind of bowel issues, usually constipation. Coming out of the hospital, you never know when the last bowel movement was. And bowels so often get overlooked and not talked about for obvious reasons. But there's so many symptoms that are related to constipation specifically. Decreased appetite, nausea, abdominal pain, agitation, urinary retention. This is when I am a real visual person and I keep a trifold with me at all times. And I say, so look, if you're constipated, it's pressing on your bladder and that's why you can't pee. And it causes all these more pain and discomfort. And especially when somebody has disease process in their low pelvic, the pelvic floor, low back, hips, there's a lot of pressure, tumor, edema, and you have constipation on top of that, you have a lot of increased pain.
And I always tell my patients, I'd rather have them on the loose side than on constipation side.
Right.
You know, we're aiming to have frequent bowel movements.
Yeah, and I tell new nurses, this is really important. It's a quick story, but it just shows how important bowels are. I had a gentleman in his late 50s with severe cardiac disease. He'd been in the hospital 7 times the last 2 months. They didn't know what to do with him, so they sent him home on hospice. And I admitted him, and I'm like, so how's your bowels? Oh, they're fine. I'm like, well, tell me what fine is. Like, give me the details. Come to find out, this man had been chronically constipated for years. And every time he went into the hospital, he was on the toilet bearing down. Well, we got him on a bowel regimen that prevented, and he was having regular BMs, and kicked him off hospice and saw him 2 years later.
Marry that stool softener and laxative to any time you start a narcotic. Anytime.
Yeah.
They got to go together.
Yeah. And what happens is, and it's classic, and people for years are on the yo-yo effect. They get constipated, take laxatives, have a blowout, stop taking it. Constipated, take a bunch of blowout, stop taking it. And it's all about prevention with bowel management. And, you know, preventing constipation is really pretty easy. You need to stick with your agency's policy, however you handle it. I almost never use an enema, the pre-filled ones or a bucket enema. I can think of twice, maybe I have. But I do use 3 main things. But first I'm gonna back up. You have to find out what's the bowel history and what their pattern is. And you really, on page 7, there next to the PR medications, it's a bowel tracking form. Have them write them down. I find people don't resist that at all. So keep track of their bowel history, find out what they're currently using. And a rule of thumb is prevent from the top down, treat from the bottom up. My first line, and some people go back and forth with Sen and Miralax. What's the proper word for Miralax?
Polyethylene glycol.
Thank you. So I start with Senna. I usually start with once a day or twice a day, but my average is anywhere from 1 to 4 tablets, 1 to 2 times a day. And that's my routine prevent from the top down, and it's important that they get it in routinely, even when they're feeling loose. But just don't overdo it, because if you overdo it, and they have a blowout, they're not going to trust you very easily on this again.
It's true.
So you got to go slow.
So many patients use DocuSate. That was used in the past all the time, the stool softener, and we don't use it at all. But you will, of course, find patients that come on with DocuSate.
And love it.
And so, again, we don't rock the boat if it works for them. But our doctor, if she sees it on a med list, she's like, what is the DocuSate doing there? Let's try to get them off of it.
But that's based off, there's a profound amount of studies out there showing that DocuSate is ineffective. It does soften, but it causes no stimulation. And actually, then if you do get stimulation, it just has soft stool in there that's not moving. Second line is day 2. They've not had a BM. Well, in the morning, I say take a full cap of Miralax. And if I find that we need to do that consistently, I'll either up the center or just add in a routine Miralax. Day 3 of no BM, that's when we work from the bottom up to treat constipation and a couple of bicycle suppositories, 1 or 2. It sounds graphic, but it's important. You gotta get it along the bowel wall lining. If you have a rectum full of stool and it goes into the stool, it's not gonna work. The bicycle has to melt on that bowel wall. It causes irritation, and then it causes, and so you have lubrication and stimulation, and it causes this quiver effect up the bowel to get things to start moving down.
Your patients who have neurological disorders like MS or Parkinson's, can't be active, they lose that ability to push out stool. So I just admitted a patient yesterday who had terrible bowel issues for a long, long time. Finally got him on just a routine that he is just regimented about because it actually works. And that was, for him, it's just taking his Miralax at 5 o'clock every single day. And then on the third day, he gets himself on the toilet and administers a bisacodyl suppository so that he gets full emptying of the rectal vault. That way, over those 3 days, he's not smearing, because people hate that smearing.
Yeah.
It's really great for people if they can't push out all the stool, just give them a suppository routinely, get the vault completely emptied.
The last thing I talk about a little bit, and it's graphic too, is disimpaction. It's horrible emotionally and physically for patients, for nurses as well. And so the idea is to always prevent that, and instead of going straight to disimpaction, if there's a bedside commode, what I'll often do is I'll go ahead and use 2 or 3 bicycle suppositories to get them to really melt in there. Set them on the bedside commode with the bucket down and massage, use a hot towel and pressing around the rectum. And even with women, you can put 2 fingers into the vagina and press, and that will sometimes start to stimulate rather than going for disimpaction. The other thing that we do, I've done occasionally when it gets severe, is instead of an enema that kind of just goes everywhere, I'll take a 60 ml syringe, irrigation syringe, put a red rubber catheter or a Mentor catheter on it, and then I'll snake up that catheter above the blockage.
Go right through the stool.
Yeah, and I just keep pressing some KY jelly in as I go up there, and then and that bolus gets on top of the blockage and then pushes it out. The first time I ever did that was with an 8-year-old who hadn't pooped for over 2 weeks. And the family had this huge celebration, and they actually waited.
Yeah, it helps if you even stick that tube of lubricant in the microwave for like 5 seconds to get it nice and warm and really liquidy.
Right.
It really works.
Okay.
Fortunately, we don't. If you've done
Yeah.
good bowel management, you don't have to do that very
Right.
often.
And that's really the biggest trust builder.
Yeah. So moving on to breathing, one of the most severe symptoms that we have with discomfort that we see with patients, and it really needs to be addressed very, very quickly. So I want you to close your eyes, think about jumping into a pool or a pond or a lake, and you went too deep, and oh my gosh, it's a little scary. I'm gonna get to the top, and you wanna get to the top, and you're feeling that anxiety of the next breath. That's shortness of breath, and it is one of the most distressing symptoms that any human can feel, and is one of the symptoms that we have to manage in hospice care. And it is distressing not only for the patient, but the family member who's witnessing their loved one not be able to breathe. Some patients with long-standing lung disease, you've watched them, they're breathing 28, 32, and you say, gosh, are you having trouble breathing? No, this is fine. They are so used to being short of breath that they don't even recognize the amount of energy that it is taking for them to get air into the, oxygen into them. I always ask a patient, and I tell the family, are you thinking about your breathing? And if they say they are, you're short of breath. That's the definition. If you are thinking, when's the next breath, or they're talking to their loved one about it, and I say
You're aware of it.
You're aware of your breath, there's something wrong, you want to fix it as soon as you can. Here's another way. I wish you weren't using all of your energy for for breathing. You're using all the calories you're eating just to breathe. I worry that you're not even aware of it. And have you considered one of the rescue medicines? I wonder, again, if you would be willing to try it. I think this is so important for our patients with respiratory symptoms, because as you will see, you can do any kind of treatment. Of course, start with the basic treatment, but if you can't get them comfortable, they're going to need a medication. So what are you going to do first? You're going to sit them up. Get them in the best position, arms away from their chest, up on pillows, sometimes leaning forward onto a table with a pillow on it. Put a fan. Start breathing with them. Teach them a relaxation breathing. Let's breathe in for 4. And let's blow out for 8. Start breathing with them at their speed, and then you slow your breathing down, and then they will slow down a little bit too. Check their lung sounds. Can you hear that they're wheezy? If they are, or if you're not quite sure, listen to their breath sounds and find out if they're on a med neb. Did they take their nebulizer? Make sure that they've taken all of their regular medications, in fact. And then if they have med neb and they're wheezy, give them a PRN treatment. The other thing, if
do they need a little bit of steroid?
That's true, and steroids are so important for shortness of breath. And I didn't even mention, if they're on oxygen, say they're on oxygen continuously, you can turn up their oxygen generally for 30 minutes, get them comfortable, and then turn it back down to their continuous rate. Be really careful for that COPD patient. Like I just had somebody, a caregiver who didn't understand, turned it up to 5 and the patient almost stopped breathing. Just wiped out that respiratory drive. So of course you have to be really careful about that. If they're not on oxygen routinely, of course, if they've got it, turn it on PRN and use it during that time. But again, we're gonna probably, if you've done all of the care of getting them comfortable and they are still short of breath, you're gonna start having to use a medication. And generally, the #1 medication for shortness of breath is a narcotic of some kind. Get that oxycodone or the morphine, start whatever, and get them a PRN dose. If it hasn't helped in 20 to 30 minutes, you might consider repeating that dose, or if they're very anxious, get that benzo or whatever you're using for anxiety on board too, so that they have both of those adjunctively helping them calm down and slow down their respiratory rate. Again, one thing about oxygen I want to mention is don't jump directly. It's never my first choice. So they don't have oxygen, but they're short of breath. You're going to want the narcotic first. We don't want to add a support system that is going to extend their life artificially. Although the narcotic is certainly helping them be more comfortable, but we're not going to add oxygen unless if you can't get control of their symptoms with medications, then perhaps you would go to an oxygen.
And I can speak just a moment about oximeters. Most nurses carry one in their bag. I just in the last 6 years started carrying one, and most families have one. I really try to say, I'm not worried about the number. We expect the number to go down. I'm really concerned, how do you feel in your breath?
Yeah.
Because studies show how we feel in our breath and the oxygen number doesn't always correlate. And I'm like, I get them to focus on how they feel in their breathing and not on the number.
Right. Generally, I only use my oximeter a few times, but during transition or active dying, I might use it. I tell the family, I'm only checking so that I can tell you more where they are on their path, because that number helps me educate and comfort the family.
The only people who will never give up the oximeter number are parents of pediatric patients. They need those numbers, and I never try and take that away.
Okay, moving on.
Big one, eating, drinking, and swallowing. So the goal here is full enjoyment of food and safe swallowing for as long as possible. And for many of us, food is love, as much as it is nourishment. And losing the ability to swallow can be distressing for patients and families because we eat to live, and it's how we show love. So there's obviously a lot of energy tied up in this, and families pushing to eat, and patients agreeing to eat when they don't want to because they're caring for their family who wants to feed them. I watch it all the time. I try and never come in hot and heavy with, well, we really need to stop eating and pushing the fluids and all that, because it just puts them on their back foot. Rather, I come in and I try and focus on good symptom management that's going to promote a return of a little bit of appetite and some enjoyment of food for some time.
And really do some assessment to find out what are their favorite foods. And I tell the family, you got to have those in the house. The patient's job, I say, your job is to say what you want, and the family's job is to get it there as soon as possible while they still have a little bit of a taste for it.
Right, and often it's not even the food, it's just the smell of it, the taste of it, the ritual of it. We know that calories are no longer important, but enjoyment and safety is. We also, normalizing that there's going to be a decrease in appetite, and eventually they're not going to be able to swallow food, and that's normal and to be expected. And remember, the body knows how to die. And I find it interesting that at about the same time when people are losing their appetite and their ability to swallow, their physical body starts to shrink. At the same time, their voice is getting weaker, they're disengaging. It's how that life bubble is shrinking and disconnecting. The body does really know what to do in this situation, and just if we could lean into that. Swallowability is really often correlated with our energy level. I have a gentleman who loves to show up to feed his wife dinner at night in the memory care unit, and but he's like, well, she's not eating much and she's not very awake. I said, well, maybe you should switch to breakfast. And so he's like, oh, there's an idea, because by the end of the day, she's lost strength. And remember, modeling giving food for enjoyment, small bites. I did know a man once in a memory care unit a long time ago who literally fed his wife to death, and he just would force her mouth open and get food in there, and we never got to the bottom of what was really going on there, but she died of aspiration pneumonia.
One thing Brenda and I actually did for each other at another conference is we demonstrated what it's like to actually feed someone and be fed. I think we've all had the experience of feeding someone, but it's a very strange feeling to be fed. So we challenge you at home, try it and see how that feels.
Yeah, with a loved one, and let alone having a stranger coming at you with food. Some verbiage here that I often use is, I wish you were not already at the point where Jack no longer wants to eat and it isn't safe for him. I worry that if we push, he may choke. I wonder if it isn't time to let Jack's body be quiet and not have to work so hard. You can show love with a lot of other ways, just by touching him. We have tips on swallow precautions, and we sometimes forget the basics. We all know to sit somebody up, but waking up the tongue, moistening the mouth. I have people say, okay, stick your tongue at me 3 times. And that laugh that can promote, opens up the mouth, gets the muscle going, but get that mouth moist before you try to start giving food and fluids, and then give a little bit at a time.
And of course, if you notice that they're really having trouble swallowing water, the hardest thing to swallow when it moves so fast over the tongue and the palate, then sometimes you might want to add a thickener. Generally, people don't like the taste of it with water, but in a juice or something, that doesn't matter.
Yeah.
Or switch to a nectar thick liquid.
And also remind caregivers, tip the chin down to swallow. It's a natural thing to put the head up, but it's always tip the chin down, and that'll help avoid aspiration. I want to talk about medications to stimulate appetite a bit. In the old days, there was always Megace and Marinol, which really I don't see used much anymore. They're expensive, and we find not really that effective. Probably your biggest bang for your buck is a real low dose steroid. And steroids are an art. You've got to be working with your hospice doctor on, everybody has their different opinions on it, but there is an art to it. And over the years, we used to do huge doses of steroids, and we're down to really small doses. For example, dexamethasone, 1 or 2 milligrams, really can help stimulate an appetite and other benefits without all the side effects.
I love being the one to suggest a steroid because they have so many benefits. The increased appetite, increased energy, decreased pain. And after you get that steroid on, you feel like you've waved the magic wand, and
Right.
they just love you.
Yeah. And it's important to not try and sell it too hard, and that they have buy-in. But I find myself saying, when it's my turn, I'm taking steroids. And so it is a bit of a sell, but what that does in that statement, it says, I'm gonna die too someday. I'm gonna be sitting in your spot someday. That creates connection, and that creates trust. And then when I say that, they like, well, you can try a little bit. And some people, it's a real mood lifter, and others, it just makes them jittery, and it's probably not a good drug for them. I just had a patient say, I went off that med, I'm turned into a witch. Actually, witch isn't what she said, but she's like, I'm not a nice person right now, so we took her off.
So moving on to one of the problems related to ingestion, it would be nausea, vomiting, and that sense of queasiness. Many patients, they think of queasiness, sick to my stomach, and of course we want to get that handled as soon as possible because we want them to enjoy eating and drinking for as long as they can. And often it can be such a bothersome symptom, it can be even worse than pain, that sense of,
It's very distracting.
you can't really think about anything else. And so we do want to find out what we can do about that really quickly. And if they're not able to, you're not able to get this under control and they decrease their actual intake of fluids, it can really hasten their death. Their dehydration speeds up much quicker. So find out first, assess, is there a time of day? Did it happen just once? Is it related to a medication? Is it something you ate? You just ate something bad and then you vomited? No, but if there's an actual pattern, then it's time to really pay attention to it and get that pattern handled. First of all, again, it's really simple stuff. Sit up, make sure that you're in an upright position. Try a little bit of ginger ale, flat Coke, tea, ginger tea, something like that. See if that settles their stomach first. And if it doesn't, then you're probably going to have to go to an anti-nausea medication. We love Haldol. Just half a milligram to a milligram of Haldol can really decrease nausea. We use that even over the lorazepam, which also is good for nausea, but again, that's more sedating, so people accept the Haldol better. If it is a problem that you see, it's every time they eat, then you can schedule their antiemetic 30 minutes prior to a meal. So if they're just nauseated, of course, do what you can, just as we said, and maybe use a medication to actually address it. Brenda reminded me yesterday that there are these they call them C-bands, and they're tight wristbands that have little acupressure points on the wrist. And sometimes they can be really helpful, so try that. If the patient is moving on to actual vomiting, if they're actually vomiting, let them finish. Do not try to interrupt that, even if it's a mess. And, again, you're probably going to need to look at it. Is it a one-time event? Is it happening regularly? Sometimes I have a patient right now who gets into coughing jags that are so extreme that he actually causes himself to vomit. So we're working with him to understand he needs to get a narcotic on board to slow down that coughing spell to relieve his emesis. He doesn't really need an antiemetic, so you need to find out what is going on that's causing this vomiting. If you're going to replace fluids after emesis, do not give them anything for at least a half an hour. Make sure that they're not going to vomit again, and then really go slow. A tablespoon of clear liquid and wait 30 minutes, and then maybe 3 or 4, no more than a quarter cup for another 30 minutes, and wait again. It may seem like it takes a long time, but it's better than stimulating that and having to start all over.
Right.
Yeah, only going to say one quick thing about unchecked hiccups. They don't come along very often, but they can actually cause vomiting, and they can really be a problem. They can interrupt sleep and just make people exhausted. You can consider maybe a muscle relaxant, something like baclofen. It's really great.
Yeah, and tizanidine is a good one too because it's less sedating.
Yeah, and it will sometimes a muscle relaxant help that diaphragm to relax a little bit. Then you can actually have them hold their breath and do the usual methods.
Severe hiccups you can tend to treat with low dose scheduled Thorazine.
Thorazine, yeah,
Chlorpromazine.
And that can be very effective. Okay, how do you prevent it? Of course, with bowels. Make sure that their bowels are regular, and we ask them to eat small, frequent meals. Stay sitting up after eating for an hour or so. Schedule that antiemetic if you think they need it. And
again, steroids, low dose can be helpful to prevent nausea.
Yeah. Okay, what if there's blood in the emesis? Have they been coughing too hard and it's coming out of their lungs, or is it in their gut? If it's coffee grounds, then you know that it's probably blood in their gut. Okay, where's that coming from? Did you put them on a steroid, but you forgot to make them take it with food, or they needed a PPI, something for GERD to protect their stomach during that steroid? Try to find out why is there blood in that emesis. Again, you're going to individualize their needs and write that down in the booklet so they have general and then the very specific individual directions for their needs.
Yeah, and I'm going to back up for a second. You want to be thinking, why could there be blood in the emesis? But oftentimes we don't know and we're not going to find out. And some nurses come in wanting to treat a disease process instead of a disease symptom. Always focus on the symptom. You may or may not know what's going on. It's important to understand disease process. It's important to understand body organ function, but focus always on what symptom is presenting itself, address that.
And to be a good hospice nurse, you have to let go of always knowing the answers. I had a really good friend who came into hospice, and she was very much a diagnostician, and she just was never comfortable in hospice care because she wanted to be getting to the bottom of it. I need lab work, x-rays, etc. So again, good symptom management, and you're not going to know the answer of where these symptoms are coming from sometimes.
So we're going to move into pain, and that's a big topic, and we'd eventually like to do its own little mini series and have it just pain on its own, because there's so much to talk about here, and so we're just going to touch on the bases. Pain is complex, emotionally and physically. It's often unrecognized and untreated. It's really different for everyone, but for everyone, it does consume their life's energy. It's not uncommon for people to deny pain, but admitting to being quite uncomfortable. Again, that traditional is the toughest generation we will ever see. They don't admit to pain, but I say, are you comfortable? Well, no, I'm not comfortable. So, I ask, how comfortable are you? And listen, watch them get up and move. Like, are you a little stiff there? And that they can admit to. So in a nutshell, control of pain management, getting control of pain and pain management. Assess the pain. What is the current regimen, if any? Make a plan that is acceptable and realistic. Put a system in place that is safe and works. Document the PRNs. We're going to talk about that a bit more. Add in a long-acting opioid when you see that they're waiting for that next opioid PRN dose, and adjust as needed. So pain management or assessment is so much more than a number. It's you have to be creative, and you have to be a good listener and observer here to find out how much pain are they having? How much is it getting in the way of their life? Yes, it's important. What kind of pain? Asking those questions, where it's at, when it comes, to get a sense. But the biggest thing is, how much is it getting in the way of your life?
And as they decline, you're going to teach that family member how to read their body for signs of discomfort.
Right.
Because some of your dementia patients, of course, they're not going to be able to tell you that they feel uncomfortable. And in fact, lately, when a dementia patient is a little bit of agitated, instead of going to something related to their neurological issue, a lot of times we'll just start with some acetaminophen and find out, are they actually painful, but they can't express it. They don't know what to say.
Yeah. So open-ended questions are, how comfortable are you? Where does it hurt? Tell me how you're feeling in your body. I ask that one a lot, and people can really, they can be very specific with that question. Fear of pain medication can even be bigger than fear of pain itself. And anxiety feeds pain, and pain feeds anxiety. They are twin sisters. I will often say, I feel confident we can make some adjustments to help you feel more comfortable. Would you like to hear those? And it's important to let them be in that driver's seat. I often say at this point, I'm the hired help. I work for you. I'm going to give you some options. You choose. And that's important. Good pain management is really multifaceted. You start simple, you go slow, and you go low. And you start in steps. You first start with the basics. Care is treatment. I often get these calls from a facility and say, "Should it really painful? Can you get here?" And I get there, and they're all crumpled down in their bed. They're ice cold. Their shirts all crumpled up around their neck. I'm like, okay, so first thing we do is we get them comfortable in bed. Are they cold, hungry? Do they need to pee? Just take care of all the basics.
It's kind of like if you had a child as a parent.
Yeah,
and they're
like
crying and they can't talk yet. So yeah, you're trying to figure out what do they need, going through all those
and
basics.
even if they're not confused, they're just overwhelmed with their bodies, and they don't know what they need. So let's start with talking about Tylenol. Tylenol is one of my favorite medications, and I would say the bulk of my patients are on a 500 milligram tablet 3 times a day, and I'm lucky if they get it in 3, and they often take it just 2. There's a lot of evidence on Tylenol, shows that it's best used low dose routinely. So, and there's two reasons I use a 500 milligram tablet. One, 500 is sufficient. You don't need 650. And it comes in that old tablet that's coated and easy to swallow. So if they get in, 1,000 to 1,500 milligrams a day, that's still well under the maximum daily dose. And people, it really helps with sleep at night, just to help, if you're more comfortable, you sleep better. So I really tend to schedule that. There's NSAIDs, and they can be very helpful to decrease inflammation, but you need to be careful. With age and disease process, they can mean they can have poor kidney function, and NSAIDs can not only be hard on the kidneys, but hard on the GI tract too.
And if you're using both Tylenol and you add an NSAID because they can tolerate it and it's helpful, you might consider alternating them. I really like to alternate drugs. Tylenol, one of them every 6 hours. And I do that with benzos too, or the sedative medications, lorazepam and Haldol every 4 hours. So you get the benefit of both things. So consider alternating meds.
And you want to do that when they're more bedbound and somebody's providing care. But when they're up and about, I try and keep it as minimal as possible,
as simple as possible.
And if you're going to do NSAIDs, put a PPI on. And alternate to NSAIDs, steroids. They're the biggest. They're kind of the godfather of anti-inflammatories. And I tell people, when you got a sliver on your arm right here, what does it get? It gets all big and swollen around it. So when you have a tumor in your body that's this big, it feels this big because of all the swelling around it. And again, I pull out my trifold and I say, this is where your tumor is, and it's all swollen around there. We're going to try and decrease some inflammation around there. Again, you have to have a really good working relationship with your hospice doctor, and because they're going to have very clear guidelines as what they like to do, when to use steroids, when not, dosing, which ones, all that. But they can be very beneficial. Moving on to opioids. So standard practice for opioids is to have a long-acting and a short-acting. You always start with the short-acting, the PRN dose, and people use it as much as they need. But it's very important that you establish how much PRN is being needed. And you have to be very creative to get to that number. It's great if people can write it all down and be accurate, but we all know that doesn't happen often, which is why I like to pre-fill syringes. There was 10, 7 have been used, and I know how much is being used. Or if I'm really unsure, I keep a log on my computer how much morphine was in the bottle that visit and now this visit. So because it's really important that your hospice doc know those numbers so they can convert to a long-acting. And generally, once you have a long-acting, your breakthrough dose tends to be 20 to 30% total of that long-acting dose. And so work with your physician on that. First step opioids tend to be hydrocodone and tramadol. Lots of tramadol being ordered these days because nobody's getting much Norco anymore with the opioid crisis. And we're not seeing really much codeine being ordered anymore, although some old people love it and they ask for it. Morphine. It remains to be the gold standard for both pain management and shortness of breath. It comes in both long and short acting, and it's the long acting, the smallest tablet you can get is a 15 milligram tablet, and it lasts for 12 hours, but we often don't start twice a day. I will often start with it just at night. I learned that trick from Nancy. And just do it at night, continue to use the PRN during the day, and then in a few days, add in that morning dose. Again, go low, go slow.
The patient is much more likely to accept it if you've done it at nighttime because it's going to have a sedative effect and they're going to sleep, and that's going to be good. And I always try to tell my patients that if we can use less, especially the ones that are afraid of medications, we can use a lot less medication if we schedule a little bit on a schedule rather than waiting for the pain to get bad, and then it takes sometimes 2 or 3 times and you have to wait, etc. Especially for those patients who are in a facility, and by the time they push their button and 15 minutes later somebody comes and then they say they're in pain, and then they go down to they go to the med cart, and by the time they get the pain medication, it's too little for as painful as they are.
Yeah. So then there's oxycodone. It also comes in long and short acting. OxyContin is the long-acting, but because it's usually for hospices very cost prohibitive, and also there's a big stigma around it with the current opioid crisis. We tend to use oxycodone when somebody has very poor liver or kidney function. Our standard is if their GFR is below 30, we go with oxycodone rather than morphine, but everybody's a little bit different, and it's going to be dictated by your hospice doc. Hydromorphone, it also comes in long-acting, short-acting, and even in a liquid. We don't use it, our facilities use it a lot, but I do find it really helpful for cardiac patients. It comes in 1 milligram per mil, and it works really well for their shortness of breath, even just a half a milligram. Fentanyl generally comes in a patch. It comes in lots of forms, but we generally see it in a patch. It tends to be expensive, and we have less control of it as it goes up and down for steady state. But it can be very effective when the oral route isn't really that accessible for lots of reasons. It could be a disease process. Somebody just won't take their medications.
They don't have any caregivers that can really provide meds, that kind of thing.
Yeah, so there is a real place for it, and just use it wisely. But again, the smallest dose I think is 12.5 micrograms.
Yeah.
Methadone. I spend a little bit of time on this. Methadone is it's only long acting. A dose that you take on Monday is still working on Friday. It can be highly effective used in very small doses, you can use these tiny little doses and start with a long acting, and sometimes for dementia people or somebody who I just need a little tiny bit of pain medication background, I'll start even before PRNs with just 2.5 milligrams at HS. The important and other good thing about methadone, it's long acting, so if they miss a dose, it's still working, and it's the only opioid that addresses nerve pain. And sometimes we get these people coming on with high doses of gabapentin or other nerve pain medications, and as they're going to approach transition and stop swallowing, it's a bad side effect when you're just cut off of those medications. So what we tend to do is slowly build them up to a steady state of methadone, find out what's working, and then start tapering them off of the gabapentin.
And to sell it, I often, because a lot of patients hear methadone and they think, oh my gosh, am I a drug addict? That's what they use for heroin addicts, right? So they're a little bit afraid of the word, but I sell it because I say that there's the reason they use it for heroin addicts and what will be helpful for you is a couple of things. Number one, you're not going to get the high of a narcotic. So you're not going to have quite the neuro problem with it. And also, you get that, I tell them it works two ways. Works down in your neuropathic pain at the bottom of the body, and it works centrally too. So you're getting double bang for the bucks. That's what I use to sell it.
Yeah, but you have to be very skilled and have a system for using methadone. Our system in our agency is that, when we start methadone, we 5 days follow that patient, and we never increase the dose within 5 days. And because it's a slow buildup, we either expect them to have to use more PRNs while it's building up, or just this week I converted somebody from MS Contin because they're into methadone for lots of reasons. But so we started methadone, and we did the next 3 doses of MS Contin along with the methadone, then stopped it while there was a buildup. And when we increase the dose, we either call or see them for the next 3 days. So there's lots of different systems out there, but it's important to follow a system that works.
Yeah, Brenda and I have been around a long time, and methadone, we weren't really comfortable with it. I'm going to say maybe 10 years ago we really started to use it, and our policy was that we had to go see a patient every single day for 5 days to make sure. And now that we're comfortable and we really understand how to use it, we have to at least call them during that time, generally see them again. But
and you just see it be so effective. And occasionally, of course, there's some people that occasionally it doesn't go well with, and we go right off of it. We all know that we spend a large portion of our time convincing people that they need some symptom management medications. And again, here I say, we're offering these medications because you're dying. You're not dying because of these medications. Again, we've just touched on it, and we're not going to even touch today on sub-Q and IV medications. That's a whole nother arena.
yeah. We're going to hurry along here because I'm looking at our clock, and so I'm going to spend some time now just really quickly on secretions and that end-of-life gurgling sound that is so distressing to families. What we really want to do is educate the family ahead of time so that they know that this is a possible sound that they're going to hear. I actually make the sound in my voice. You may hear this. I make the sound for them, and there's nothing wrong with it. It's natural. The patient isn't uncomfortable. It's just saliva that is being moved as you breathe in and out. So we try to really minimize it, make it part of the normalization of the dying process. So because it can be very distressing, and go ahead.
And they will stop swallowing and they will get some secretions.
They will. And so some patients who have been over, for instance, they've had so much fluid because they came out of the hospital and they've been on IVs, and they have cardiopulmonary disease. They're the ones that are going to have more difficulty with a lot of perhaps a lot of copious oral secretions towards the end. So I'm just going to quickly say what the nurses need to do. When you're hearing this, they call at 2 o'clock in the morning and you can hear the person foaming and gurgling in the background. You need to go because a family member does not understand really what to do. What they need to do is get that patient in a Trendelenburg as much as possible. If they're in a hospital bed, head all the way down, feet up, get them as close to a Trendelenburg as possible. Turn them far on their side. Put a pillow, a towel by their cheek, and turn them far enough so that secretions can actually run out of the mouth. Take a
dry swab and start pulling them out.
Dry swab. A lot of times their secretions are so thick and gooey, sticky, because they've been mouth breathing. Sometimes you can actually, you can pull them out, put your fingers around a washcloth, really sweep it out. Stimulate their cough or their gag so that you can get out just as much as possible. Then you bring them back up into a slight sitting position. If they are you're not gonna have a suction machine there. It's very, very rare. Even if you did, those Yankard hard plastic wands, they do not get deep enough. So they're not
they're painful.
They're not helpful. So if you really feel like you need to suction, just get a Foley catheter out of your bag, cut the tip off, and get another cath tip syringe. You insert it down into the throat, and as you're removing it, you're pulling back on the syringe to try to get out just a few milliliters. Sometimes it only takes 2 or 3 cc's and the sound goes away. Provides comfort, and then you can get them back up.
And good oral care helps prevent those buildup of secretions.
Absolutely. So one other thing, sometimes we do use medications towards the end, and in our comfort pack we have hyoscyamine or Levsin. In the old days we used atropine. It's expensive, so we don't use it anymore. Somebody might be on a scope patch because perhaps they're a Parkinson's patient who has always had a lot of drooling. So you may have a patient already on a drying medication. But we use hyoscyamine occasionally towards the end to not dry up. I tell the patients this is not drying up the saliva that's there. It's preventing release of more saliva. So get on top of it quickly, but not too quickly so they don't get cotton mouth ahead of time.
Because remember, they're getting dehydrated and so the secretions are going to get thicker, and then you add in these medications, and some of the newer studies are showing that these medications actually, they're not using them. Positioning and preventing with good oral care is actually better than using the medications, because
Absolutely.
when it gets sticky in there, that's when it also gets hard to move out.
Actually, that's so true. And when I try to get buy-in for the family on using the hyoscyamine, I remind them that Levsin is used for babies who are colicky, and then they immediately go, oh, that's got to be safe.
Yeah, and one of the side effects, it's great for, it relaxes smooth muscles, so if they're having bladder spasms or abdominal cramping, works wonderful.
Works great.
I tend to use the Levsin in our comfort pack more for bladder spasms and abdominal cramping than I do for secretions.
Exactly. Okay.
Skin and wound. Okay, the goal is to maintain skin integrity for as long as possible, and if there are wounds, provide containment and comfort. It's pretty straightforward, and it's all about prevention. But even if you still have really good care, great prevention, you still may have breakdown. The skin is the largest organ in the body, and as it prepares to compensate for the dying process, it loses oxygen, nutrition, hydration. They're not moving as much. Now there's pressure. So despite good skincare and prevention, you may see some breakdown into the dying process.
Even if the family is doing a great job of turning a patient regularly, they can still get breakdown, and sometimes you have to relieve their feeling of guilt that you did everything right. This is just
Their
part of
dying
the
body.
Yeah,
Yeah.
it just happens.
So, be creative with pressure prevention, egg crates, air mattresses, gel cushions, and really modeling, showing the family how to change position. We have 2 videos on positioning for comfort and how to relieve pressure off the heels, all of that. And stress that they do need routine moving, and you may have to pre-medicate if they're uncomfortable. Always keep the skin clean and dry. And Nancy taught me a trick a few years ago, and I use it all the time, especially for somebody with pericare. They're in bed, and instead of wiping everybody down, I pull out a blow dryer on low setting, and we blow dry until the creases under the breast, the groin, and pull the cheeks apart, get it really dry in there. It feels wonderful for patients, gets it dry, you get a good look at it, then you can put on the barrier creams.
A thin layer of
Well, I think, yeah.
Well, it depends on what you're using.
Yeah, I never use the zinc ones.
Yeah.
I always use a Vaseline-based barrier cream or just a tub of Vaseline because it's a great barrier, easy to move.
It melts away too.
It
It's not
melts
stuck there
away,
in layer
right.
after layer.
Yeah, but some people are really tied to barrier creams. I'm like, use whatever, but you need something on there. And then, so say they're another trick that I do too, on that coccyx when they're up to the bathroom, I said, your job is you gotta massage that area 3 minutes, 3 times a day. And if you've ever massaged somebody's coccyx who's been sitting on it for a while, they purr like a kitten. And I use the barrier cream as the massage cream. So if there are wounds, and this is a real general bell curve, but with most wounds in hospice, the whole idea is containment and comfort. I almost always cover the wound with a Vaseline gauze dressing, whether it's zero form or just plain Vaseline, so that it doesn't stick. And I like to use a foam dressing to cover that, and then secure with a tube grip or Curlex, elastic tubing. I try and avoid tape. If the wound is becoming odorous and there's a lot of drainage, I love using Flagyl spray. In the old days, like a long time ago, we used to get Flagyl tablets, stick them in the blender, make a powder, and kind of throw it on there. But now most pharmacies will have some Flagyl spray that you can spray on. It works really well.
And another really unusual tip is to, if you have a cat in the house, put a basket of or a bowl of kitty litter in the room. That absorbs odors, and it really works.
Yeah, and a time-saving tip. Like I have one patient with real complex wounds right now, and how many has spent 20 minutes in the house looking for the wound care supplies. Put it in the care plan in the home and on your charting in their care plan on your computer, so that they know where those wound care supplies are and keep them updated. That saves so much time.
It's really helpful if you've got wounds that do have several steps. I actually write them out or print them out and bring print and just tape them above the bedside too.
I put them in with the supplies too.
So that because you've got so many different people coming and going in the facilities.
Yeah.
I'm going to really quickly go through some personal care and safety. And Brenda and I really emphasize, as you've heard, care is treatment. It really is what we always start with, hands-on care. We want to provide safe, loving care, and we know that the patient eventually is not going to be able to care for themselves. So we want to gradually add that care as they accept it. Know that a patient is going to need dignity and they want to do what is best for them. They may be resistant to have someone coming in. They're embarrassed to have their body shown. So get that aid started quickly, but don't have them go right to the shower or bed bath if it isn't
Having
needed.
to get naked in front of them.
Yeah, just have them give a massage, do nail care. We carry
Foot
nail
massage is
equipment.
a great distance.
Yeah, lotion, we do nails. It's a wonderful way to get connected to your patient. As a nurse, when you're actually giving them care, they will start chatting with you so much more. We need to let the family know that there will be caregiving needed as they decline, and they're going to need a lot of care. It's eventually going to need 24 hours a day, so you're going to need to start putting that puzzle together. Who's going to take care of them? Social workers are great at putting this family puzzle together, hiring people, getting grandma there to watch the phone, whatever it is. So find out what their individual requirements and needs are. I just had a patient who was quite a fashionista, and when she was still with it and getting around, she always had a beautiful outfit on. Right towards the end when she was transitional and she was mostly bedbound, I said, Carol, is there anything else we should be doing to serve you? What else can we do? And she looked at her daughter and said, yeah, I'm tired of choosing the outfits. It's time for you to buy, get 4 or 5 and just rotate them. It's taken too much energy. And that was really a good clue of somebody who loved fashion. That really told me that she was, she was really moving along. Let them do as much as they can, of course, and be patient, because it's always going to take them longer if their facility, their faculties are declining. If there's a patient that has a neurological disorder, one of your dementia patients, and you start trying to move their body, they're going to be fearful. They want to sit. They're afraid when you try to force them into a chair. Even when they're in a bed and you start to move their body, they feel that they're going to fall, and you can get the elbow in the jaw if you're not watching. So if you've got a patient who is resistant, even belligerent to care, it is time to really look at medication management. They may need Depakote for some mood control. They may need some scheduled Haldol or lorazepam 30 minutes before you get there. The aide who's going to do the bath needs to be brought into that care plan so that they understand to call ahead when they get there.
I tell my aides, tell them the hospice nurse said, I need you to give a PRN before I get there, and I'll be there in 30 minutes.
Yeah. Use a slow, quiet voice, especially, and if you've got people there to help you, hopefully you do, don't let them start talking over you. Just one person giving directions. Do expect that a patient who has been immobile is going to be painful. Even if they don't have a pain issue, if you're in one position for 2 to 3 hours, it's gonna hurt when you move your arm. So I tell families, you must give care, and you must expect that if somebody's been immobile, it's gonna hurt them a little bit. So don't stop touching them and moving them if they just groaned a little bit. If you get them in a new position and they settle right in, go back to sleep, perfect. Their pain is completely managed. But if they can't maintain a position change and stay there, they need some pain medication. You want them to be able to receive care and maintain a position change. I think we're just going to move on from here.
Yeah. So we've already referred, we have that at the end of the book. There's a whole suite of videos, and they're free for use on both our website and on YouTube. Please access those videos, use them for your families, to teach caregivers. They're completely free. Please feel free to use those.
And you're going to start using them in this next section on transition into active dying, because this is when they really do need hands-on care. So use those videos. And transition is that last 4 to 14 days, when the goal for the client or the caregiver and the patient is to recognize and understand the signs of transitioning into the final dying process. We want them to know as much as they can so that there's less anxiety during this time. And again, as Brenda said at the beginning, this is when you plant that seed and you have them read that before 2 or 3 weeks ahead. Give them the homework. Read that page, and then if you're lucky, the family will recognize and say,
tell you,
gosh, Nancy, I think they're starting to go into transition. Don't you think so? Are we doing
and there's
everything?
so much more acceptance when they're seeing it instead of being told it.
Exactly. So, and the other thing that happens is that sometimes it's so slow to die. Families, if they haven't been around death, they have no idea that, oh my gosh, why is this taking so long? Even the patients, like, why is this taking so long? I am ready to die. Well, the body is an absolute miracle machine. It wants to live and live and live until it can't live anymore. If they get to go through a smooth transition, it allows the body to do the natural process of dehydration and all those changes that will come along. Sleeping more, going internal, not talking as much, eating very little, taking sips, and then turning their head away.
And this can be a real time of increased anxiety because they feel themselves losing physical and mental control of themselves, their surroundings. And this is where you start seeing anxiety start to rise up. You start seeing falls happen, and now we need to start probably scheduling more medication.
Yeah, and as we know in the hospice realm, falls are not unusual occurrences. In hospice, they're usual occurrences, but I know most of the time we need to document those.
Yeah, yeah.
But at this point, this is oftentimes when we'll say to the family the wish, because they're going to ask now, oh my gosh, how much time is left? Is it going to happen tomorrow? How about next week? So that's when you're going to start saying, I wish I had a crystal ball to tell you exactly how much time is left. I worry, are you caring for yourself? Because this could take a while. Are you taking care of yourself during this time? I wonder if you're setting clear boundaries for your patient and for yourself. Don't let visitors come in and stay for an hour.
Yeah.
Let me be the bad guy. The nurse says only 10-minute visitation. Put a sign on the door. Everyone, you have to be sensitive to everyone's needs,
Yeah.
not just the patient.
The hospice nurse said, I need to have you love us from there, and we need quiet here.
Yeah, and in a facility, make sure that there is an identifying sign in the room that says that they're on hospice, because when things change and you get a lot of people coming in, you don't want them calling the ED. Oh my gosh, they've started to have changes in their respiratory.
New caregivers, yeah.
New caregivers. And this is, again, where we are just constantly saying, please look at your patient, look at your loved one, and follow their lead all the time. You're going to see the oxygen level is going to start to drop, and again, this is where I might look at the oximeter and say, yeah, they're in the 80s now, and look, they're so comfortable. Great, walking along the path, everything is going exactly the way it's supposed to go. Things can change with body temperature. Don't let a family put 10 blankets on top of that little old person who was always cold. Now their body is not the temperature isn't being maintained that way, and they can get so diaphoretic. So be aware of that. Sometimes, and very rarely, we have to move a patient into a facility that can do 24-hour care. Try to avoid that in transition. It can be very chaotic.
Yeah, and try and get the chaplain, make sure that that the rest of the hospice team know that they're in transition. It's a good time for the chaplain to arrange for a priest, all those things.
Yeah, there we go.
So they've moved into active dying, and the hope is the chaos that can come with transition. They're now bedbound, unconscious, not eating and drinking, and now it's smooth running. There's a regimen that's working. I tend to only schedule meds every 4 to 6 hours. If you're needing something every 1 to 2 hours, the regimen you're using probably isn't working well enough.
Time to talk to the doc and see if you need to.
Okay, we need to bump things up, because I really try and stick to 4 hours or less, and then plus with breakthroughs. Everyone in the care circle needs to know what their role is, and so if they're the caregiver, because now the patient's dependent on you to know that they clean, calm, cared for, safe, dignified, all those things. Your role may just be there to witness or advocate. You have a family in a facility and you have to advocate care. So know what everybody's role is. So let's see here. This is a good time that you may start seeing some restlessness and the medications aren't working. You might want to think about a catheter. But also, here's what happens in this active dying phase. That's where some of the magic happens. The photos come out, the stories start. Like, tell me about how you two met. It's a really good time. Some altars come out, and it's where magic happens. And there's also this emotional shift that happens. Like, I'm ready for them to die. And I'm like, oh, what you've just described to me is true love. That's a good, healthy response.
Yeah, and if they can deal with some of their anticipatory grief during this entire hospice process, but especially during transition and active dying, they're going to have a lot less problems with their grief after the death. I like to tell patients that I'm a Girl Scout, and I always like to prepare. So be proactive,
Yeah.
and as you said, as you're teaching, before you even start teaching transition, you're teaching transition. Then you're also telling them about active
Yeah.
dying. And now,
Yeah, and just real quickly, I'm very visual, and so we are our body, mind, and our spirit. And some people are like, it's taking so long, and sometimes the body gets really close, but you're like, I'm not going there yet. Or somebody really old, I woke up again today. So it's the body, the mind, and the spirit doing this dance, and they all, when the perfect times is right, which is them, body, mind, and spirit, it's a time for death, and it's perfect. And some people choose to be alone. So
Yeah. And that's that. Sometime during that active dying, I often, if they don't ask me, I will often introduce what death is going to look like, because a lot of people aren't around death, and they're oftentimes very afraid. How am I going to know? How am I going to know that they've died? And we just talk about it in a beautiful, I like to call it a very beautiful divine spiral, that you can watch this person just slowly going down. Everything is just slowly moving towards closure, and you're going to see all those changes, and then all of a sudden there's going to be this absolute exquisite quiet.
it's instinctual to know.
It is, and you will know. They don't trust you right away, but generally they know immediately when the body has quieted. The beautiful skin turns translucent. They look younger by years because all of the worry lines go away. It's very easy to, and you need to know in active dying, in after death care, what is your policy about after death care? Every hospice has a different policy, and you need to know what's your state law is. Here in Oregon, 24 hours, no questions asked, the body can stay right where it is. Know what your state regulations are. No coroner, no medical examiner. And in our state, we don't even have to go and pronounce a patient. No. It's up to the family to choose what they want. Yeah. So you might suggest some things to do after the death.
So I always encourage ritual and bathing and dressing, but I don't push. And I want to point out how Nancy described a dead body as very beautiful. And it's a paradigm shift for a lot of people, because for some people it can seem traumatic. And when you have this nurse come, it's like, oh, aren't they beautiful? It helps create a paradigm shift.
And it can be part of the practice of being a hospice nurse, can be such a gift to be there. I'm going to tell one really quick story, because every family has different ideas of what they're going to do. This woman, Rose, she was very in charge of her entire life, including her death. And after she died, as she was dying, they were singing around her bed. And when she died, she wanted flower petals put on her. They did that. And her habit when she was a young woman, when she had guests, is she would always follow them out to the front porch, and every time when they were leaving, she would wave them off. And so what they did was they wrapped her in this beautiful quilt with flower petals. The mortuary put her into the van. Everybody went to the front porch and waved her off as they drove away.
There is beauty in it.
Just beautiful. It gives me a little chill remembering that experience. So unfortunately, generally, hospice nurses don't get to have much time to do very much bereavement. We're on to the next patient. But make sure you've let the family know that bereavement care through Medicare is a benefit, and your own community may have other after-death services. Yeah. So make sure they know what's available.
And create your own rituals for grieving. Mine is cooking, walking. I light a candle when I do my charting. Mm-hmm. Okay, so we've only touched on some of these topics, and we hope to do a mini-series that can go a little bit more in depth. We know that there's a growing need for hospice, trained hospice individuals, and because we're out there in the field on our own, it takes a long time to learn. And so where this book stimulated from is our years of experience learning how to do this stuff, and so that's why we came up with this book. And on the back cover, most of you will know two pretty prominent names in the palliative and hospice care industry, Dr. Susan Block and Dr. Ira Byock. They both early on got our first edition, and they're like, this is fabulous. And they have been willing to endorse this and continue to endorse this because they see the benefit, and that there's not a product like this out there that's hands-on.
That really tells you what to do, not just what you're going to see.
What do you do?
Yeah. Right. Brenda and I, after we created it in our kitchen, basically, we have now used we've been using the third, this is our third version, the rebranded version, which we're really proud of with all of the colors and so forth. But we've watched it in use, we've used it, we've seen nurses in our own company use it, and we're also on call. Each of us take a day of call every week. And what we have really noticed is the number of calls really decline. Triage does not get calls nearly as often, and the after hours calls, when we get them, the questions are much more in depth because the patient and the family has been so much more educated by the booklet that their questions are very much more specific. So we hope that you will use it to train your staff, to orient your staff, and it really helps to standardize the care, because then we're all kind of saying the same thing.
Yeah.
What else? We would like to share with you pieces of our booklet. And so, as Deepika said at the very beginning, we're offering some of the pages for free. You can go to our website and get a digital version or a hard copy version. If you let us know, we're happy to get one in the mail for you too. I want to tell you just one more quick thing before we open it up to questioning. Our company's name is Odonata Care. Odonata is the Latin word for dragonfly, and dragonflies represent transformation, and of course death is transformation. So we just want people to know that's why we named it Odonata.
Yeah. So again, we want a big shout out to Sheila Clark, who early on saw its value, and she's really championed us. And to Deepika, we're a couple of baby boomers who really struggled technically, and without her, we wouldn't have.
We were a little nervous about the whole.
So again, we went kind of quickly, but we'd love to take some questions.
Yeah. So we're going to turn it back to you, Deepika, to put the questions to us.
Sheila has a question for us here.
I have a lot of questions.
Okay.
You're right, I'm a fan. So question, a few. So what I'm seeing in here is you have the goal and what to do. So that's interventions. You're helping the team start a care plan.
Right. That's what it is. That's why it's named the care plan.
We changed the name
We
from
changed it,
A Path to Comfort to the care plan, kind of based on your input.
Because you're the one that helped us realize that it meets all the CAP scores questions, because it's
a care plan.
Okay, Nancy, you're stealing my thunder.
Oh,
here.
sorry. I'll let you talk.
It's what they need to know, right? It's what patients and families need to know. You've got a baseline for the team, for every team member on care plan, right? Goals and interventions, but also CAP scores. Making this part of your care plan, and this is a leave behind that you can reference to, even on call, death, what's happening, transition into dying, Mrs. Jones, remember we talked about, and pointing them back to this.
Sheila,
so important.
I do want
assisted living, golden opportunity.
Thank you.
It's and really CAP scores, because I see so much in here, and I see it at a California level. Is there's so much bad scoring on communication. You've got a great document here that will, help you through it. Because as clinicians, we go by our care plan, right? Everybody who walks into that bedside, they're looking at the care plan. What is my goal? What is my intervention? You include the patient and family in that, but what are we putting in their hands?
And Sheila, I guess
sense?
the one thing that I just wanted to add, and that we didn't say earlier, is that in our hospice, it is part of our admission packet. It isn't in a cupboard somewhere where the clinician has to remember to go take it. It is included in the admission packet, so it is in the home from the moment we walked in the door.
And when Sheila brought this out to us, we went and we read all the questions, yep, they're all there.
Is this customizable? So if a hospice wanted to use it, could they put is it okay that at least if they put their sticker?
Yes.
Or
Yes.
A great place for the sticker is right here. Our company puts their sticker right here. If you want to change the entire thing, that's a very large order. And for some of these corporate hospices, we could talk to them about that, but they're looking at 10,000 copies.
Yeah, to put, and we did personalize it at one point for our own hospice, but found that it wasn't as valuable.
Well, wasn't as cost effective.
Yeah.
Buy a sticker for the sticker.
Yeah. Right there's where the sticker.
With maybe, and maybe one on the back, how to get a hold of us, but that it's all, it can be done. But is this in Spanish?
Not yet,
We're
but
working
we are
on it.
working on it.
Yeah.
Okay.
Yeah.
Yeah.
That's
it's
the next step.
Well, I'm a fan only because we get calls here, Deepka, and they'll tell you from patients and families that they're really not sure what's going on. Because as clinicians, right, in hospice, we're all used to going to our care plan. What are we putting into the hands of the family? Because we come in, we're giving them so much information. Where can we put something in their hand? So you're right. I am a fan, and I will be quiet now in case other folks want to talk.
We so appreciate you, Sheila. You've been a champion from the beginning. It's really helped us continue. Thank you.
We do have a 30-minute video on your website and on our website that shows tips on how to use the booklet.
Yeah, so whenever somebody wants it, we give them a printed page on tips to use it, but there is a webinar, just a 30-minute webinar that goes through how to best get the benefit of the booklet.
Other questions?
Any other questions, Deepka?
Looks like no other questions. Yeah, so Brenda and Nancy, on behalf of CHACA, I so very much appreciate you presenting for us today. Just a quick reminder, I wanted to let everyone know that CHACA is holding an annual conference the week of June 6th to the 10th in Orange County. We're going back to the basics of hospice care. We hope you all join for the week of education. Other than that, it looks like we will conclude our webinar.
Unknown participant is now exiting.
Hi guys, thank you.
Thank you.
Thank you, Sheila.
Thank you very much. Appreciate you.